Thanks, Philip. That was excellent and raised a number of important issues, I think, in relation to management of child TB. But I'm going to go a little bit more offshore now and just to some of the broader issues, perhaps give a brief update on some of those issues and around strengthening services or opportunities to strengthen services for TB in children, not so much in adolescents. One of the research consequences of COVID for the CRE is we've lost our particular leader in adolescent TB, Catherine Snow, to COVID. She's doing a great job for the Victorian Department of Health on COVID, but not so engaged so much at the moment. Maybe we'll get her back one day. Anyway, I'm going to talk about just the search, treat, prevent, those issues quickly. And I think you're all aware that there's significant gaps in terms of detection. Children, WHO estimate that the case detection gap is particularly large in children for reasons I think we all understand. And even people living with HIV, as we saw yesterday, quite high uptake now of preventive treatment, but still a major gap for even young children who we know are a high-risk group. Treatment success, we now have countries, more than 80 countries using the new fixed-dose combination for young children. Treatment success in children should be very good and is in many countries, but 73% in one country, for example, which is actually Papua New Guinea. And I don't think we really know how much MDR-TB there is in children. There's a major gap in detection in that area. So, as part of his PhD, Ben produced these data from the pre-BCG, pre-treatment area of what is the risk of disease following infection. I always use this slide. And you can see that the risk why children are such a vulnerable population in terms of developing disease and often severe disseminated disease, which BCG provides some protection against. And so we understand why preventive treatment is focused on young children. But it also highlights, I think, that a lot of TB in children in TB endemic settings presents in young children, and that has a particular diagnosis. Even here in Australia, we get 50% bacteriologically confirmed. In most settings, it's going to have to be a clinical diagnosis in a setting where you have a lot of children with severe pneumonia, meningitis, malnutrition, etc. And to try and find TB amongst all of that can be challenging. But these data have been updated more recently. Leo Martinez has done an individual participant meta-analysis, and people here have provided data for this, including Rena Triasi and Justin and others. And what you can see is that the story remains the same on more recent data. There's a high risk of around nearly 20% of children under 5, if they become infected, will develop disease. And most of those will present early. And this goes to what Katie was. There's issues we're talking with Katie yesterday, particularly in the under 5s, the presentation is early. And what is important from a programmatic point of view is that if we want to detect either early disease or prevent, we need to have prompt contact screening and management. Now, the development of, or the rapid development of diagnostics happened some time ago in terms of child TB. But there is a lot of attention at the moment to doing better by better sampling techniques. A lot of countries now recommend expert first line for diagnostic for child TB, which is understandable given that it has a higher yield than smear microscopy. But there's also quite a lot of interest in getting different samples, including stool, as a way of getting sputum from young children. And I've just summarised there the data that we have now in terms of sensitivity and specificity. But the important point, I think, is that when it's been done under programmatic conditions, most of these data come from tertiary hospitals such as in Cape Town, diagnostic studies. But in terms of programmatic situation, I think for children presenting with presumptive TB, expert identifies TB in about 10%. So still a large number of children not bacteriologically confirmed. Expert Ultra has a slightly higher sensitivity than Expert, but there's this question at the moment about the interpretation of what's a trace result. I think many of us are not particularly convinced that it's specific for TB disease. Just quickly, there's a number of studies that I've involved in, which, for example, RAPID study or TB speed. The RAPID study is a study that will evaluate biomarkers, and it's recruited. It's happening in a number of different countries, and it's recruited almost 1,000 children now, and it's got quite a high level of bacteriological confirmation, and also a group of children who are TB unlikely for comparison. And they've come from work that was done previously and published from Tanzania, in collaboration with German on a particular novel T-cell activation marker. But they're taking a lot of samples for a range of different biomarkers. The TB speed study, which is Unitaid funded and happening in a number of countries, is actually a more pragmatic way of trying to get rapid diagnosis in children with the most highest risk of dying from TB, and seeing if we can improve diagnosis in those children, and does it lead to reduced mortality, using sampling such as nasopharyngeal aspirate and stool and Expert. So that study has finished recruitment for children with severe pneumonia. There was a lot of interruptions with COVID, etc., but these studies are still ongoing. But I think the holy grail is, well, there's a number for child TB, but clearly improving diagnosis and a point of care diagnosis is really essential. And in the past, the focus was very much on distinguishing between those without infection or disease, those with infection, and those with disease, as taking them down different management paths. But I think more and more now there's interest in also not just identifying those with infection or having had infection, but actually trying to identify better those with infection who are the most likely to progress to disease. And that's an important area. At the moment, as you know, for preventive treatment, for example, we just use a blanket. If you've been exposed to TB in the household and you're under 5, you'll get preventive treatment whether you've been infected or not. So this is work that's ongoing in a number of settings, and is now looking at in adults as well in terms of screening populations, ruling out active disease before treatment for infection, etc. More interested in this subclinical group. A question I guess we have in pediatric TB is the day going to come when the same regimen can treat, that might be multi-drugs such as rifampicin isoniazid, might effectively treat both whether they've got infection or subclinical or non-severe disease equally as effective. And that is certainly a plausible situation for the future. So this is the findings from the SHINE trial, which will be published before the end of this year, and it's been presented already at the union meeting. And this was a randomized controlled trial of non-severe disease in children and adolescents, and most of these were pulmonary disease. They were not smear positive because that was an exclusion, but some of them were certainly bacteriologically confirmed with Expert. And one group received standard treatment, and the other group received a shorter regimen of 4 months. So a shorter continuation phase of just 2 months of rifampicin isoniazid, and using the fixed dose combination as the treatment. And essentially, in terms of the primary endpoint and all the other endpoints, it showed non-inferiority. So it was done in a number of different TB endemic settings. The primary efficacy outcome was unfavourable outcome, defined as treatment failure, recurrence, death by any cause, or on treatment loss to follow-up. And there was also safety data, but the drugs that were being used were not new. And so this has shown that there was non-inferiority of using a 4-month regimen against a 6-month regimen in children with non-severe TB. The fixed dose combination is widely used now in more than 80 countries, including Australia. That's been recently introduced. And one of its other potential advantages is it can also be used for a preventive treatment regimen, the 3RH. And so that's an area where there's more and more work being done. And there are other formulations that are currently either being prioritised or under development for children so that we can better manage children with second-line drugs and MTB. There is also a Rifapentine product that will be suitable for children under development, along with PK studies and safety studies in younger children for Rifapentine. We've opted for a single Rifapentine, not a fixed dose combination, which gives the flexibility then of using it because it may be more challenging if it was to be given as a fixed dose with isoniazid. Treatment of infection, I think we all understand, is very effective in children, and these are again part of Leo's recent update, just particularly focusing on the finding of the effectiveness of isoniazid preventive treatment when a child who was a child contact had baseline infection, so an effectiveness of 91%. And it's just interesting, we've highlighted this yesterday, I think Suman referred to this, that isoniazid has been shown, at least in this study from Peru, that it may even have continued effectiveness in MDR contacts. But just to summarise some of the options at the moment, I think certainly my sense is that the most suitable combination in terms of the short regimens at the moment is 3HR daily for young children, because you've got a child-friendly dispersible medication, but also Rifapentine is not recommended currently in children under 3, though they're a very high-risk group. But as an alternative to at least 6 months of isoniazid, I think 3RH is probably the most suitable of what we have at the moment. And this is a study we did with the union, really just implementing 3RH in TB endemic settings, and it just showed a very high uptake of 91% with excellent adherence. These were all young child contacts under 5. They were followed up for at least a year, and it was shown to be safe and perhaps effective in that there was no TB while any of these children were on 3RH, and just one case after stopping, and well tolerated. So just finally, I think a really big issue for child and adolescent TB, and particularly child TB, is to try and decentralise the services, which have been traditionally very focused in tertiary, large hospital, facility-based settings. And this is just to highlight a number of pieces of work we've been involved in. Chris yesterday highlighted some of the work that Sasi Lestari has been doing in Papua, Indonesia, around in the Timika district, preventive therapy and child contact screening. This is a study that also received some seed funding some years ago from CRE of supporting household screening of MDR contacts in Mongolia, which is just implementation work. Previously, we've supported some work in Vietnam around the communal health centres and just supporting the implementation of contact screening and preventive treatment for young child contacts. And I think one study that I just wanted to come back to was the pilot work in Uganda, which was really well done, and it basically was supporting health workers at the primary and secondary care level, strengthening their confidence through training and mentoring to look after children with TB and preventive treatment, And this led to a large increase in child contact case detection of children, but also in adults in the same area, including bacteriologically confirmed. It led to improved treatment outcomes, and it implemented community-based household screening and contact management, including preventive therapy, in settings where it had not previously happened, with high uptake and high completion. So I think there's a lot we can do in that space, and we continue to work with the group in Uganda, establishing a child and adolescent TB Centre of Excellence and supporting child TB working groups. Suman has already discussed the issues for a high prevalence setting and what would be the right regimen to be using in that context. And I just want to shout out to the support that we've had there and how critical it has been around education, counselling, community engagement, education, and I think Angela highlighted some of those particular issues yesterday. The WHO is now in the process of updating the child and adolescent TB guidelines, and they should be complete. That process should be complete by the end of the year. But these are some of the areas around the cascade of care that are actually particular focus of attention in the PICO questions, etc., that we've been involved in. So thank you very much.
Might have time for one super quick question.
Sorry.
The BCG shortage and BCG vaccination catch-up, has that been affected by COVID, and the extent to which efforts are being made to catch up with BCG?
I don't know what the impact of COVID has been on BCG. The shortage issue was resolved largely before COVID came, so that UNICEF was very much involved in that, and that had much improved before COVID came along. The impact from COVID, I'm not too sure.
Yeah, Steve, it's just for those on Zoom, Jeremy here from Centenary Institute again. Thanks, that was a really interesting and comprehensive overview. I just wanted to make a comment or just a thought on the choice of regimen for children, 3HP versus 3HR. And I completely appreciate the work and the emphasis that has gone into making those child-friendly formulations available and how well accepted they are. But just on the 3HP, I think reflecting on our experience in the Marshall Islands, where we offered different TPT regimens to a few thousand households, I think that for some there is a group of those children who are slightly older, where if you are doing a systematic screening and have a whole family, that offering the choice, that some of those families certainly found it quite acceptable to have a whole group of people on weekly treatment, even if it's not a family, even if it's not a child-friendly formulation, and it's a little bit more of a hassle on that weekly treatment day, that it's quite helpful sometimes when, to do it all at once, and not have to chase around one kid with a dispersible formulation. Certainly in the youngest kids, and it's only for 2 and over, or 3 and over, whatever it is. But yeah, it's an interesting note, and we'll get better with Rifapentine.
Yeah, no, I think I'm very much for wanting everyone to be on the same. The problem at the moment is Rifapentine is not widely available, expensive, but also it's actually not recommended for under 3s. So you've still got the problem of the youngest kids. And at the end of the day, the fixed dose combination is only really for kids under 25 kilos. We would say that children, adults, older children and adolescents should really be on the same regimens as everybody else.
Thanks very much, Steve.